It's my pleasure to introduce the last speaker, which happens to be my boss. Hamish Jamieson is a geriatrician with Te Whatu Ora, Waitaha, and also an associate professor with the University of Otago in Christchurch. He has been involved in interRAI research for over 10 years and believes that understanding health data will lead to improved and more efficiently targeting of care. So Hamish's presentation is around care distress among community living older adults with complex needs in the pre and post COVID-19 area, national population study. So over to you, Hamish.
Tēnā koutou katoa, and thanks for the introduction, Ulrich. Unfortunately, I was planning to be there with you today, but unfortunately I couldn't make it. I've got a little bit of a cold as well. I don't think I got it from John Hurdy's last week. I think my daughter goes to preschool and I got something from her. Fortunately, it's not COVID, but I'm best not to be there spluttering around. Look, while I fortunately don't have COVID, this talk is on COVID. And it's just reflecting on what Gary said at the start of this. 5 years ago, when we had our first knowledge exchange, we were all in that same room in Wellington, and we didn't know what was about to hit us. But it's quite interesting, and I think relevant that we're doing this today on COVID, because in the last 5 years, it has changed our world and put a lot of stress on us in ways we couldn't imagine beforehand. But what I wanted to do today is talk about carer stress and what was effectively happening during that in COVID. Because one of the beauties of interRAI is now that we have standardised assessments in Aotearoa, we don't only look at cross-sectional or time point data, we can look at longitudinal trends and what's happening to these variables over time. And we've got such a great data set. This study was partly looking at long-term trends in carer distress as well. I'd like to thank my co-authors, Professor Philip Schluter, who's an epidemiologist, and Rebecca Abbey Nisbet, who did her PhD with us and is now working for Stats NZ. Annabelle Ahuri Driscoll from University of Canterbury provided Maori consultation. And Ulrich was part of our esteemed team, who I should say since he's introduced me. But also, I think Jackie and Sally are in the audience there today as well. Look, when we look at challenges to older people, there's many different things we think about. We think about falls and cognition. But one of the biggest problems that families report is carer distress. And some of the biggest drivers of putting people into rest homes isn't the actual falls or cognition that people have. It's how much carer distress is on the partner or loved ones of the older person. And it's not exactly the number of conditions, but it's how much they're reporting carer distress. And in this study, we wanted to look at use interRAI data to look at carer distress in Aotearoa over time, and not only look at the changes over time, but to look at the COVID-19 effect, and then also some relationships between participants, socioeconomic and other health measures. So, as I said before, we've got a large number of interRAI data going right back to 2012, and actually even before 2012 when we were using the old form of interRAI. But in this study, we looked at repeat interRAI home care 9.1 assessments in New Zealand, which had been done continually for that 8-year period. And we used functional polynomial regression and multi-level mixed effects models to look at it. And I'm going to try and keep that a bit more simple statistically for the people who aren't statistically minded. But over the 8-year period, there were 140,000 older adults greater than 65 who had an interRAI home care assessment. And these are people who were living in private homes and receiving informal care. So before I go there, I just wanted to talk about what is carer distress in the interRAI. There's 3 questions in the interRAI related to carer stress, and if people answered yes, or families answered yes to any of them, then we recorded the person as having carer distress. So the 3 specific questions were 1F7D, the family or friend feeling overwhelmed, IP2A, informal helper unable to continue caring, or IP2B, informal helper expresses feelings of distress, anger, or depression. So that's how if people answered yes to any one of them, we record it as carer stress being present. In the interRAI data we looked at, the median age of the first interRAI home care assessment was 82 years, and approximately 60% were female, which is interesting since John's in the audience, very similar to what's recorded in Canada. The majority of interRAI assessments were European, but there was 6.1% Maori and 3.3% Pacific. So what do the actual results show with caregivers' distress over time? And when I looked at this now, I wish I'd actually included the actual graph because it would make it clearer. But I will talk through this with you and explain it. So in 2012, in the interRAI home care assessments, 31% of caregivers reported distress. So that was answering yes to one of those three questions in the interRAI related to carer stress. There was actually, in the graph if I'd included it, would have shown it, that there's been a steady increase in carer distress from 2012 to 2020. And in 2019, before lockdown, approximately 47% of families reported carer distress. And if you look at the graph, it's a clear, almost linear increase every year in caregiver distress. During the lockdowns, in 2020, we had lockdowns, but we didn't actually have much COVID in New Zealand, as people remember. It was still quite stressful and quite unprecedented and challenging. But interRAI assessments continued as able. There were some over the phone, and they weren't able to do them exactly as we could. But from the data we had, the caregiver distress in COVID increased to 48.5%. So from what it was in 2019, which is about 46%, there was only a very slight increase in caregiver distress. At the end of the study period in December 2020, the prevalence of caregiver distress had dropped down almost to what it was in 2019, which was 47%. So the main trends from this for me is that from 2012 to 2019, there was a definite linear increase in caregiver distress. There was a minor increase with the COVID lockdowns in that first year, but that returned to baseline levels by 2020. We looked, in terms of the COVID impact, there was a small but significant increase in distress with COVID, but it wasn't nearly as big as the increase that occurred from 2012 to 2019. If we look at carer distress further and break it down, there was higher caregiver distress reported among female caregivers and among spouses and partners as opposed to extended family. And there was also, not surprisingly, reported higher in carers of individuals with cognitive impairment and dementia. Caregiver distress was also, again, not surprisingly, higher for individuals with higher levels of dependency as measured by the MAPLE and ADL scores. But interestingly, Maori and Pacific caregivers reported lower distress, which Annabelle Ahuri-Driscoll pondered was possibly linked to wider whānau connections in multi-generational households, or perhaps it wasn't reported the same in Maori and Pacific as it was in Europeans. But there was that definite lower distress in that key demographic group. So, look, in discussion, what interRAI is a whole lot of tools, a whole lot of different ways we can cut data and add it up and analyze it. But one of the things we looked at, which I think is really important and one of the biggest ultimate costs to the health system, is carer distress. Because what drives people into rest homes, which is one of the biggest costs of older people, isn't actually what's happening to the person, it's how stressed their caregivers are. And understanding that is really important. We have noted with these longitudinal interRAI data a linear increase in carer distress over time. And interestingly, John Purdy's, when he gave talks last week, also said the same situation was happening in Canada in the last 10 or 20 years with carer distress. So it's interesting we're getting the same in both countries. But I think it's really important to be aware of this. We all think we're getting busier, and people say life is busier, but it's good to have some data to show it. And interRAI with longitudinal analysis is really useful to look at these long-term trends in society. And obviously, it's having a lot of impact on people, on caregivers, especially women, which have a higher amount of carer stress. And it's also important to look that COVID-19 made caregiver stress worse, but wasn't a big primary driver. And there were other important studies on interRAI and COVID-19 led by Gary Chung, looking at rest homes and how people were in rest homes and falls and things like that as well, which I won't go into, but interRAI has looked at a lot of things in relation to COVID-19. In more conclusions, I think caregiver stress is a big problem we need to be aware of, and it's great to put data around it. With our current health system, it's becoming very data-driven, and services that have been done always in the past because they have been done need to be re-justified. And I think it's really important to understand, first of all, that carer distress is a big driver to rest home entry, and a big cost, but also it's increasing over time. And for organisations such as Age Concern, which fund the caregiver supports and visiting services, and other groups that are looking at funding caregiver distress, this is giving really useful data that caregiver distress is increasing. And in our previous studies, which I'm not talking about today, I've talked about at other interRAI conferences, caregiver distress is clearly related to people entering rest homes, and is one of the bigger risk factors for people entering rest homes. So in the future, I think it's important to put a number. Anyone in health can bring up talk, but the way health systems are going to be funded are on data, and what is the data showing? And clearly caregiver distress is a growing problem, which our previous work has shown is clearly related to rest home admissions. And I think ways we can reduce the stress on caregivers, such as mental health support and other gender-specific or cultural sensitive ways to reduce carer stress, will be important to be aware of and to have on the funding scope for Health NZ as they go forward. So that's my talk on caregiver distress and COVID.
Thank you, Hamish. Any questions for Hamish? Oh, okay, arms go up.
Hi, Hamish, it's Sally Heppenstall here. It might be a question for interRAI New Zealand. I'm just wondering where the carer stress scales up to in New Zealand.
That's a good question. I might hand that over to Marg. Or John might have an update from Canada.
Who wants to take that?
Here's Sally's question.
Carer stress scale.
Oh, okay, yeah, I can answer that.
You're in the software more than I am.
No, so Don Guthrie from Wilfrid Laurier University created the CARE algorithm, which is a composite measure of caregiver distress and hours of informal care and a couple of other indicators in that. You can derive that from the home care instrument, not from the LTCF and not from the palliative instrument. But it does give you sort of an overall sense of how much caregivers are dealing and how stressed they are. That has both objective exposure measures as well as the subjective response to it. You can use that as a triggering tool to identify further intervention. What I was going to add to Hamish's talk was 2 points. One, interRAI now has a new self-reported care assessment of needs. It's a caregiver assessment that they can self-administer and self-report. We have 12 countries in the pilot study. One country is missing. It's in the South Pacific to the east of Australia. Yeah. So we would very much like somebody who's interested in caregiver issues in New Zealand to work with us on testing that out. what it's intended to do is to look at the carer's needs, so their physical and mental health, their perceptions of met and unmet needs for themselves and for the care recipient. There's a quality of life dimension to it as well. There's a bit on health service. So everything that the ZERA caregiver burden scale fails at, this is an improvement on. And so it can be used for care planning and for outcome measurement and different things. The other thing is that we've established a new sub-network within interRAI on caregiver issues that we have people from these different countries participating in. So if you're interested in getting involved in international caregiver research, this is a network that we can connect you with as well.
Thank you, John. Any other questions for Hamish?
Thanks very much, Hamish. Sally Keeling here. My question is actually for the wider room about our thoughts about how this access to data, which at one level isn't entirely new, but for me, the question into the future is how do we translate this into service design? And specifically in response to today's presentation, I'm concerned about respite care services, because that traditionally was a way of giving carers a break. And the total invisibility of any national package on access, supply, funding, resourcing of respite services seems to me to be just such a big gap. We don't need to be convinced again and again and again about these measures and these scales, but what as a country can we do about it?
I think, Sally, I might answer
Very
it.
good
Then
question.
I might answer and then leave it to anyone in the room who's from Health NZ. But you're right. I think with this new health system, they are data hungry. And if we can put data to them and show the cost of certain things, that resources will follow. So it's really partly us, and if they're open to it as they're reviewing funding, if we can show them data, they're more likely to be able to make these sort of changes. But is anyone from Health NZ in the room who would comment?
Well, I'll just make a comment on the respite stuff from the cross-national finding, which doesn't have somebody from New Zealand participating in. Two things. One is that there's this tendency in Canadian governments to say, well, we'll fix the caregiver problem by giving all caregivers a $100 tax break, and that'll be fantastic. We'll send you $100, and then you can care for your elderly relative for the rest of your life. The other thing that there's a tendency to do is to say, oh, well, if we just get caregivers some more education on how to do a safe transfer, that'll solve the problem as well. When we ask the caregivers internationally, everywhere except New Zealand, internationally, the number one unmet need that they refer to was respite care. They need the break. So yes, they asked a little bit about education, but respite care was by far the big issue.
Thank you, John. And Sally, I have a comment. Last year I presented a similar study where we looked also in carer stress. And one of the comments from our Maori collaborator was, yes, there are lower reported numbers, but that doesn't mean it's not happening. It's culturally embedded, but it pops up in a different way. Can you imagine what that would be? But one of the concepts that came out of this piece of research was, in some ways, government needs to tailor the intervention packages to the cultural groups in the country. And the equality discussion, in a way, concerns me in that respect, because for Maori, it may be far more fitting to have a whānau support model, whereas for me and my family, a respite care model in a facility may be the more appropriate one. So, but how do I or we make that happen? I don't have an answer to that.
Just with regard to respite, I think we need to be thinking broader about what respite is. Traditionally, it's been a bed in an aged care facility for short-term stay. So NASCA recently did a piece of work looking at how we can use the interRAI data louder. I don't normally get told to be louder. NASCA did a piece of work around using the interRAI data to try and get some consistency around allocation of respite. And when we did that, we also looked at converting that not just into bed days, but it might be carer support allocation, which just has, last year became more flexible, possibly in danger of that being turned back. But we need to be thinking about individualized funding to allow somebody to make their own decision about what respite would look like to them. Because for some people, it might not be a break away from their spouse or their loved one. It might be having the funds to be able to do something frivolous with them. So I think we need to be building that in. So the work has been done, but of course we can only make the suggestions. We can't put it into policy. But I think we're all thinking along the same lines. And I've certainly been working with Laurie Hilkson from Carers NZ, who also has done a lot of work in this area.
Thank you. Hamish, I've got a question looking back at the research today. Do you think there's sense in diving deeper into geographic areas, for example, or deeper into socioeconomics to see, do we have a specific subpopulation, a group of people in New Zealand that are more exposed to carer stress?
Yeah, definitely. I think it's worth looking for patterns in those areas and seeing where the actual need is. It may not be even. And you raised a good point before about Maori and Pacific needs as well.
Okay, thank you.
Could I just,
Oh, okay.
could I, Hamish, Tim Foote here from MSD, I work in elder abuse. Just curious, two questions. The first one was just a simple one. Are there further breakdowns around the severity of stress? Are there indicators there in the scale that's tested for?
Not with this. I think, as John alluded to before, there is a new self-reported. The interRAI doesn't go into ultra detail in that, but there is a new self-reported caregiver assessment of needs that's being reported. Another instrument that's being reported as well.
Okay, cool. Thanks. Yeah, so the statistics you're quoting includes all levels of stress.
Yes. Yeah.
Gotcha. Cool. And then the other question I had was just if you've looked at or are considering looking at the relationship between caregiver stress and the triggering of the ACAP.
We haven't looked at that yet. Well, that's something we could look at in the future. It's a good thought. And just one point also I was thinking about before, we've done a lot of caregiver and loneliness research in the last 10 years. We're putting it all together in a summary and trying to put it to the Healthy NZ so they've got it all in one point so they can see all the research that's been done.
Okay, thank you, Hamish.